HFMA moderator for today. Welcome to this HFMA webinar, How Claims and Reimbursement Data Can Fuel Operational Recovery, sponsored by LexisNexis Risk Solutions Healthcare. Risk Solutions Healthcare. We have Richard Grape, who is the Senior Director of Strategy of the Claims Analytics Suite for LexisNexis Risk Solutions Healthcare. In this role, he acts as part futurist, part visionary, and as a strategic leader that directs the overall market, product vision, and sales strategies as it services healthcare and government nationwide. He holds a Bachelor of Arts from St. John's College and a Master of Public Administration from Cornell University. Tim Kringle is a Senior Vertical Solutions Consultant with LexisNexis Risk Solutions Healthcare. He serves as the subject matter expert for data analytics related to medical claims. Tim draws on his 10 years of experience working with medical claims data, as well as his background in consulting and analytics to advise LexisNexis customers across all sectors of the U.S. healthcare system on how to best optimize their business and operations based on medical claims data, as well as providing solution design and consulting advice. So with that, Rick, I'll turn the presentation over to you.
Thank you, Linda. So this is Rick Grape with LexisNexis. First, I'd like to thank you all again for joining us today. During our session, we're going to discuss a few different things. We're going to start with really outlining the power of claims analytics, specifically how claims and reimbursement data can fuel operational recovery. To kick off our session, we'll begin by taking a critical eye at some of the industry trends that were already shifting the market in a pre-COVID world. We'll then take a look at some of the challenges that were encountered as healthcare shifted to providing care in the midst of the pandemic. And finally, we'll jump into how these forces drive and create the need for data and analytics, which ultimately can be used to drive really the future of operational recovery. So let's kick off with a look at some of the major industry trends that are impacting health and hospital systems in the broader healthcare market as we moved into the early part of 2020. While COVID has resulted in a shift in reprioritization of a bunch of resources and priorities across our businesses, these factors are nonetheless relevant and top of mind in addition to those needed for tactical pandemic and disease response. Many of these have seen a need for infrastructure investment, adoption of infrastructure over a short window of time in the absence of things like telehealth being supported by different practitioners and facilities. So we'll take a look at those among others. To start with, I'd like to talk about our first industry trend, which is really the move from volume to value. There's a few different things that make this up: pay for performance, prepaid care management and quality scoring, performance-based reimbursements across programs, accountable care organizations, and ultimately global capitalization. This market shift is really hallmarked by a strong shift towards alternate payment models, or APMs. These are indicative of the value-based care approach that we've seen being adopted over the past several years. Level setting, as we all know, healthcare about 10 years ago was insurance that was paid largely in volumes. Over the past decade, we've seen the shift from a number of services to the quality of those interactions, ultimately with market attention driving an increase in accountability. Volume-based reimbursements are still commonplace, though, and they're beginning to trend more and more towards value-based care models. In today's market, we really see four different categories. Category one are traditional fee-for-service payments. These don't typically have a link back to quality. And the payments in these are not adjusted to account for infrastructure investments, provider reporting, or any kind of quality type metric. Category two, which you'll see on the screen, are fee-for-service payments. These are linked back towards quality. So payments adjusted based on different infrastructure investments, improved care for clinical services, whether providers report on data quality or performance and quality metrics as a whole. Category three are really the APMs, or the alternate payment or APMs that are built on a fee-for-service architecture. So these are moving from mechanisms for effective management from a set of procedures and episode of care, or potentially for all healthcare services that are across the board. Category four, in that final category, these are really population-based payments, and these are driving providers to deliver person-based payments, driving them to be person-centered in nature. These payments hold providers accountable for quality and ultimately have person-centered goals, including preventative health, health maintenance, health improvements, and acute and chronic care services. So as we look at kind of the shift of these across the board, you'll see that APMs account for currently about 35% of payments, but surprisingly, these represent about 77% of the covered population, or roughly 226 million Americans in the U.S. This shift also represents a move that we'll talk about in just a little bit, and that's the move to consumerism, more and more of that patient-centric approach across the board. And while fee-for-service continues to represent a high percentage of these payments, fee-for-service is ultimately under decline. We've seen a 2% decline in the last year alone, with many industry goals set to see alternate payment models grow by about 50% or more within the next 5 years. So now I'd like to shift our focus a little bit from the need to impact outcomes, costs, and experience to some of the more tactical blocking and tackling that can be done to drive this change. One area that we're seeing this change really start to shift is in the area of patient responsibility. Over the past few years, we've seen patient responsibility become top of mind across our industry, and patients are being charged more and more with greater ownership of the financial burden for their health care. This is hallmarked really with that shift to PPO or high deductible plans, and employers are seeing paying ultimately less for those PPO plans as a result of the patients adopting it. The result, patients pay more out of pocket, and this is ultimately changing their buying decisions. If you look to the right, you'll see that in a recent survey from Bloomberg, the percent of Americans who had moved already to high deductible plans has grown pretty considerably over the past 10 years worth of time. These numbers are coming from 2017 as the last point in time where kind of that holistic market assessment was conducted.
As we talk a little bit about some of the price transparency things, as I'm sure just about everybody is aware on this call, there's some new legislation in play and some court battles that are going on. But this predates the current things. This is one of the interesting things that I think both sides of our political parties agree on, is a need and desire to have more price transparency. If you go back to the actual Affordable Care Act, there were some parts of that and some follow-ups from that that resulted in some legislation. I believe it was January 2019 it went into effect, where all hospitals had to publish their price lists. Well, that didn't work out very well. What you found, and if you go out there, they're still there, is charge masters buried on hospital websites. And if you're a consumer, you can't do anything with that. I live in the world of medical claims data, and I would struggle to go through the 456 pages of ICD-10 and CPT code charge amounts on the hospital website. You can see the example that we have on the screen. This is page 456 that you would have to click through to find the cost tied to the procedure. And that cost, as you know, that's coming from the charge master, not what's actually going to get the allowed and negotiated between insurers. So that was sort of the first foray. It didn't work in terms of what the goal was for the patients, but it passed. Well, the new legislation and the Trump administration passed probably did learn a little bit from that, and they passed some additional ones that require to understand what the people pay for services. So getting at that allowable, what's the negotiated rate between the payer and the provider. So that's obviously gone through some court challenges. There's a lot of strong opinions on that. Nobody's asking my opinion. My gut says it's probably going to come into play. It probably gets delayed with COVID and some of the impacts I would expect, and probably hope that there's some delay in that because there's other priorities that we have right now. But we're moving in that direction. There's no question that's the direction that we're going to go, and that consumers are going to begin to shop for healthcare. And that leads us into some of the next topic that we have here, which is not just the patient response, or not the patient responsibility, but the payment amount, but the move to consumerism. So if I take myself as somebody who works in the healthcare industry, but also as a consumer of healthcare, if I needed to get an MRI, I'm now going to price that. 10 years ago, I wouldn't have. But I'm going to know what it's going to cost me to get a spinal MRI before I go in and get it done. I'm not just going to take a referral from my PCP to go over to a particular radiology center. I'm going to find out, is it more cost effective for me to use an outpatient facility or a standalone imaging center, and what are their negotiated fee schedules that they have with my insurance provider. This is becoming more common, and we are starting to see, as Rick alluded to earlier, that shift to the HSA and the cost tying to consumers. Well, once you push that cost to the consumers are going to shop. And it's harder to shop for healthcare than it is for things on Amazon, but it's gonna start to move in that direction, and we all recognize that. I know, Rick, you had some real life experiences with this recently as well.
Yeah, and I think you're right on point, Tim. So effectively gaining consumer mindshare and really ultimately keeping their interactions and associations positive is really critical, especially in the marketplace that we're in today. Consumers really can pick and choose where and from whom and when they'll receive their individual services. As an example, my wife and I recently had a baby, so it's our first. There's obviously a lot of different challenges ahead of us. She's just turned a year, and there's walking and crawling and teething and sleepless nights still on the horizon. But that said, like so many life events, where we chose to have that baby ultimately will greatly determine where in the future my family will likely go to receive health care. If you have insurance with a doctor that didn't require you to go to one hospital or another, you're likely going to miss out on a number of different future client life events. And as a result, a potential pretty large amount that each individual patient could bring to your health or hospital system over the course of their lives. Our daughter, for instance, entered the world with some difficulties, but the hospital we were at met those challenges. They earned our loyalty, and honestly, if we have another, we'd be back.
And as we move on to the next slide here, Rick, what you'll see is that lifetime value. So as Rick talked about now being loyal to the organization that helped through his challenges, and by the way, his daughter is absolutely adorable. I just had to put that plug in there for him. But that lifetime value of the patient is estimated at $1.4 million. Some other statistics, I don't need to read through all of them, but we all know if you're engaged with your patients and you're engaged with them and you have them and you understand you're going to get less medication errors, you're going to reduce things like falls, you're going to reduce length of stay, readmission rates, all of these things that are beneficial to the patients, but are also starting to really impact the economics of the health system as they get into how the reimbursements are going to be handled, and as the shift we move away from, volume to value and look at quality and not just quantity in terms of payment mechanisms. So you'll see, the different topics that you have in play here, the patient experience, engagement, these type of things can help you ensure that you're keeping that patient within your system and providing the care that they need. We'll talk a little bit later about telehealth and how that plays into this. That's a key part to this as well, is, what's your virtual strategy and things along those lines. So in summary, and you can move to the last slide in this section here for sort of the industry trends, there's a few that we wanted to highlight here today. The shift from volume to value, from quantity to quality. We all know that's going on. It's going to continue, et cetera. The shifting costs of the patients. Again, not surprising, but we know that that's coming. And what does that result in? It's resulting in new legislation for price transparency. It's resulting in more consumerism and patients shopping for healthcare. And what are you going to do as an organization, as a health system and a provider? Really understanding, the who, the where, the cost, the options that you have, and having the data and knowledge about what those things are is really going to help to drive your organization to the next level. And with that, we have our first poll question of the day, which is your system prepared to meet the new price transparency requirements? And we put 4 options in here. We are fully prepared. It was a priority before the pandemic. We're not currently focused on it. Or the last one, we hope it gets overturned. And you can only pick one. So we'll give a minute here to allow people to chime in with their answers. I'm curious, we don't have a poll question too. One of the things, because we don't play in the world, but anecdotally, I've been talking to folks, what is the economic impact of that? How are they going about, figuring out just the IT and the technology side of how you're going to publish this information, and do you even have all that data at your fingertips? So there's a financial cost as well as just another one. So Rick, I'll get your thoughts on this too. This is what I expected. I wondered how many people really wanted to say D, but the priority pre-COVID, that was my guess, was going to be there. Interesting that a quarter of the people said they're currently not focused on it. And I can't blame them. There's a lot of other things that have priorities, and 18%, so 19 out of the 100 or so people on the call here are fully prepared for the new legislation, the new requirements. I don't remember, Rick, I'm not sure if you know, I should have looked this up before the webinar. Is there a date? Is it Jan 1 that they're supposed to have everything go into effect? We can follow up with that after the webinar as well.
Yeah, please do that.
Okay. Yep, I saw panelists, yeah, so Jan 1, so thanks, Angela.
All right, well, thank you, Tim. So we're going to shift into really the next part, looking at some of the different challenges that have come during the course of providing care and throughout the pandemic. We're all feeling the impacts, obviously, of the current pandemic from COVID-19. In recent days, we've seen how the population across the globe has been impacted. And really, the pandemic has a number of different traits that distinguish it from any other that we've really seen within modern times. One is definitely that high mortality rate. So it's been heavily on the elder population, those with one or more chronic conditions. Being able to gain insight and transparency into some of those comorbidities is something we're going to talk about at length during our discussion today. Another is it's highly infectious, so it has a much longer incubation period, causing significant spread from unsuspecting or asymptomatic individuals. We've seen within the short window of the pandemic high demand and a shortage for critical life supporting equipment, things like ventilators, respirators, dialysis, ICU care level equipment, as well as skilled critical care professionals. Recognizing the potential for Lexis, which is the company we're working with, to help support some of the different customers and clients throughout the healthcare industry that have been impacted by this, we embarked actually on an industry initiative to help bring together both our data assets and analytics, along with those other industry stakeholders throughout the healthcare ecosystem, in order to give really a line of sight into some of the critical needs that they might most be struggling with and needing some guidance on. So we'll talk a little bit about these over the course of the upcoming slides. But really, as we all work to overcome the different challenges that COVID has had and the strains that it's put on our businesses, these are areas that we found kind of top of mind, areas that folks have reached out to us and some of the support needs for their individual health and hospital systems, and areas that we want to highlight as potential sources of risk if you're not currently paying attention to them. So to begin with, let's talk a little bit about the pandemic across the United States. It's clear that COVID at this point in time knows no borders, as every geography and every community and population within the United States has at this point experienced just about some level of exposure and loss. Looking at this map, you'll see a percentile breakout. This is looking in kind of a heat map fashion across all the different confirmed and deceased populations originating from really one of the industry's leading data sets for COVID, and that's the Johns Hopkins data set. As we talk a little bit today about some of the things Lexis has been doing, we've been bringing different data sets together, and the Hopkins data that we've seen through GitHub is one of those that seems to be the most complete ever reporting entities across all of the healthcare ecosystem. So as we talk about some of the things that Lexis has brought to this, and if you haven't had a chance to check it out, definitely recommend, I got to put my plug in here, to check out our COVID-19 Data Resource Center. The LexisNexis Healthcare Business Unit has a mission at its core to help build healthier communities. Amidst the pandemic, there's no more important time for us to be doing that and to offer our resources to do so. So LexisNexis, if you're not familiar, is an industry leader bringing assets together and to bear from across a number of different key data sets. Our business unit has 3 major different data assets, and these were all brought into the Data Resource Center to provide different levels of transparency. One of those is a provider data asset. So we bring one of the largest county level capacity level databases of practitioners and facilities across the United States. And we do this to assess some key specialty provider risk as we look at our Data Resource Center today. We also brought a very large repository of de-identified medical claims, and this is coming from our market view suite that has about 2.2 billion de-identified medical claims to help provide some of those insights into the different populations that might have comorbidities or be at risk from a population lens. The third data asset that we brought to bear, and we'll talk a little bit about, is our consumer public record information. And this includes things like socioeconomic risk factors, which could also represent high risk or the potential to prevent optimal health outcomes for populations within the United States if they were to be left unaddressed. So we'll take a look at each of these over the next few slides. In addition to the data that we brought to bear, looking at things like our 837s and 835s that we see from our de-identified medical claims, we also pulled in industry resources, provider data, not just looking at practitioners that were on the books, but those that are emerging. We've seen a wealth of NPIs that have come about as students graduated early from schools, as new testing and temporary facilities were stood up to help support the pandemic response. Facilities, again, is a key piece. So we've seen a number of different care capacity areas of focus, but looking at which offices, which treatment centers, et cetera, are current, emerging is an area that we're actively tracking as part of the pandemic response. Socioeconomic data, as I mentioned before, there are several different risk factors and can potentially shine a little bit of a light on at-risk populations outside of those that might be either aged or have specific comorbidities that have been found to be a specific risk factor tied to COVID. We'll take a look at hospital hospital and facility data, things like hospital beds, ICU beds, their availability, and then ultimately even pharmacy and clinic data. So we know that a number of pharmacies have actually stepped up to the table to provide not only testing services, but minute clinic type consulting services. And this is an area that we continue to look at ongoing potential sources for risk as the pandemic continues to expand. So we'll take a look really at two main questions as we talk over the next little bit. And this is really what our Data Resource Center sought to answer. The first one is which communities are most at risk for poor health outcomes due to COVID. As COVID has continued to spread throughout the U.S., health policy officials, practitioners, hospital systems, and others have really been challenged to identify the potential extent of population impact, as well as to gather intelligence on where they could have a greater impact to help flatten the curve. To do this, there really is a baseline that needs to be understood for where risk exists and where potential risks exist within the population. So we did this by bringing together our de-identified medical claims and looking specifically at age and comorbidities, also coupled with different socioeconomic risk factors. And then as we continue to respond to requests from the industry throughout the course of the pandemic, we started breaking that up and looking at individual health risks and conditions. The second question that comes to mind most frequently is an area of response is which communities are most in care of resources to help combat really the impact of COVID-19. So obviously all of these different entities that are looking to make strategic decisions on where there's additional provider specialties that are needed to treat patients that have come down with this are attempting to do so in many cases within the sphere and realm and view of their own individual network. And being able to look across networks, being able to look at neighboring facilities, neighboring hospitals, to gain a better understanding of exactly what opportunity exists to leverage some of those outside resources is something that we endeavor to do by bringing some of the different provider data assets to bear. So we're going to talk about each of these questions in a little bit more detail, the first of which is really that high-risk population. So as we were talking about the three different kind of categories of it, the first is those age and comorbidities, looking at those that were 60 and above, and those that had 2 or more high-risk comorbidities. So we looked at things like asthma, cancer, chronic lung disease, coronary artery disease, hypertension, heart failure, diabetes, specifically areas that different populations, different clinical research had brought to bear and highlighted as potential sources of potential risk among populations with those comorbidities. This is a review of relevant market literature, clinical guidance, and different CDC recommendations that went into that short list. As we were encountering different questions on the individual health risk, it brought up a need for us to actually break this out and do an individual view. And this is when we started to look at specific subcategories like age and heart disease or diabetes, hypertension, lung disease, these individual areas that have a variety of different potential diagnosis and treatments that are required, but ultimately fit into some level of bucket or aggregation that can be broadly applied and looked at specifically by specialty providers that have common background. The last and third vulnerable population factor we chose to look at was socioeconomic risk factors. So there's a number of different, and I know the industry, socio is kind of a hot buzzword at this point in time. There's a number of different areas from a socioeconomic lens that could be looked in terms of the population that's at risk for the pandemic. We look specifically at those in this instance that had different financial indicators, economic stability factors, things like housing stability, financial health indicators, to help draw attention to which population could be at higher risk, and specifically whose socioeconomic needs, if they went unaddressed, would be likely to prevent optimal health outcomes should they come down with the COVID diagnosis. I'd like to spend a moment and kind of use an example of this. Diabetes, I think, is a good example of diabetic population that is impacted by COVID. In and of itself may receive treatment and go into different hospital and facility networks. But specifically, if that risk factor is identified up front, different plans or hospital systems have an opportunity to help engage with them through things like Meals on Wheels services, things like that in the event that they're in a food desert. If they don't have access to stable communication through cell phone use, stable transportation to get from one location to another, maybe to a grocery store, being able to mitigate those and ultimately the long-term risk if those things were to go unaddressed, especially during a pandemic, is an area of mitigation that we wanted to shine a little bit of a light on. So outside of these factors, the risk ultimately came back as a result to a couple of different potential resource gaps that might be needed to address these populations that were in that high-risk footprint. One was provider risk. So we know that there's a number of key specialty providers that have been in high demand since the start of the pandemic. Things like anesthesiologists, cardiologists, critical care, hospitalists, internal medicine, infectious disease specialists. This high-risk population has been an area that we've received a lot of outreach as different providers and facilities are attempting to identify other practitioners with those specialties that they can either bring in network, that they can bring in as local tenants providers, or that they can leverage from a neighboring health or hospital system in the event that they're in a heavily impacted area. Similarly, from a care capacity risk, hospitals, in terms of hospital beds and their availability and ICU beds and their availability, is something I know we've seen a lot of publication on the news that everyone is well aware. These are critical and scarce resources that ultimately are receiving high demand as a result of ongoing need for medical treatment. So before we continue on, I want to talk about how some of those risks are being mitigated in the upcoming slides, but I'd like to pause and kind of ask us a polling question. So that question is really, when did your organization start feeling some of the financial hardship due to COVID-19? Was it in March, April, May, June, July? I know we've had the pandemic hit us in waves throughout the United States, and some communities were more affected earlier than others. Some are starting to feel the effects of that now as we've had spikes in different geographic locations. So just curious there. Tim, is there anything you'd like to add to that? I know we've kind of talked at a high level at this point about some of those risks and risk gaps, or care capacity gaps, essentially.
Yeah, I think that you hit the nail on the head with that section. I'm curious what we're probably going to see here, I'm guessing in the results of this poll question here is a geographic distribution of who signed up for the webinar. So I wonder if we plotted a chart geographically, we'd be able to see where, the hot spots and things like that. So March and April, so I'm up here in Branchburg, New Jersey. We went full shutdown. Luckily, family and everybody's healthy for me, but we're not in the New York area. We're on the western side of New Jersey, but we were in the, full shutdown. So nothing was happening. So we were in the early, definitely would have hit everybody up here in March, April, and then a few folks in July. That's interesting that some of the places really didn't last that long. You'll notice we took off one of the answers on this when we first started, which was haven't had any, just because we figured that has not happened to anybody. I can imagine there's a health system in the country that has not had some impact, because even if patients just being scared, if there was nothing there going into the organization. So interesting.
All right. So let's talk about how the industry is starting to shift in order to address some of those critical care gaps and potentially reallocate and re-engage folks outside of the typical face-to-face settings that have been commonplace. So obviously, many different organizations have started to adopt telehealth. Telehealth being any of the telephonic treatment for a broad range of services, interacting with patients. Really, this has gone in place as many practitioners have started using it for patient evaluation, diagnosis, and treatment. The expansion of telehealth we've seen nationwide has not only helped support the continuity of care for most of those routine and regular office visits, but also to help support social distancing requirements as folks want to avoid and not potentially be in areas where there could be points of potential infection, ultimately reducing and limiting some of the patient exposure to that. Those with high-risk comorbidities we're seeing a high adoption of telehealth services. We've seen spikes in that area as those at-risk communities are starting to be more and more aware and still in need of ongoing continuity of care level treatment for whatever comorbidity they might have. Telehealth, in many ways, is starting to help bridge the gap and reduce patient care risk across the board. And we've seen that as practitioners are starting to do this and adopt these services, that it also has opened up a wealth of opportunity for providers to be able to render their services to communities that are at risk regardless of geographic location. So we've seen a wealth of practitioners helping and lending a hand from different parts of the country through telehealth services, through consultation, by managing populations in areas that might be dated and more heavily affected. So when we took a look at this, and you'll see on the screen right now, there's a trend chart, and this is looking with 2019 really as a baseline of historical volumes, looking at the adoption that we've seen of telehealth claims really by week compared to the same time last year. So you see, as we entered March, these claim volumes were relatively low, consistent to what we've seen historically. By the time we're in April and even into early May, we've seen a significant spike. In this case, it's over 8,000% increase across the board in terms of the number of telehealth claims that we've seen. Based on different levels of reopening from the different parts of the country being shut down to different holiday weekends and things like that, and I know we'll talk about that a little bit, you'll see some of that deviation in the lines overall. We then chose to take a look at this, also focused specifically on the specialties that went from very low volumes, so what would have been potentially hundreds of claims in 2019, to those that suddenly had hundreds of thousands of claims for the very first time. So this chart actually uses, and it looks just at the top weekly increase, so this varies quite a bit if you do visit our data resource center. You'll get a chance to see where these trends and which populations, which practitioners have suddenly started adopting telehealth services for the very first time. We saw early on specific spikes in gastroenterology, assisted therapy, as well as areas that we would have expected as we've all been struggling to some extent with isolation, things like behavioral care. As a parent, when pediatricians started having the ability to do telehealth appointments, it was a relief. Being able to suddenly be in contact with our practitioner, not just calling through the phone and trying to navigate through those lines, but talk to them face-to-face and troubleshoot as was needed, it was a welcome change and relief for our family. I think as we kind of look to the future, we can expect post-pandemic, a lot of these trends will continue. I know it's currently a temporary measure to allow for this level of telehealth adoption, but we're also seeing that many providers are starting to embrace the telehealth technology, not only to maintain contact with their current population, but ultimately to be more convenient to that population. I think that goes back to the initial lens we were talking a little bit about with consumerism, and really the need to engage that population more effectively, keep their buy-in and mind share. As a patient, I know every time I need to go into the doctor, it's a chore. I have to get an appointment, I have to take time off of work, I have to drive a long distance, I have to sit in the waiting room potentially for hours. And I had a telehealth appointment just 2 days ago. It was on time, it was quick, I was in and out. There was no problem. I got a chance to talk to my practitioner. I fortunately had a blood pressure machine and the scale, so I was able to give the basic stats that they needed. But it was a great way to really ease some of that strain that's going on with our populations across the board as they're interacting with practitioners and seeking to keep their care current amidst everything else that's going on. I think post-pandemic, we'll see that. We'll see that consumers will have a demand for that. It will be consistent across the board. And with this kind of in mind, I think I want to shift over to kind of our next polling question, which is, has your organization successfully adopted telehealth services? As we've talked with different practitioners in different health and hospital systems, many of them had telehealth in place, but many of them didn't. There was a strategic initiative that was long-term on their plate with the goal for the future. So they started adopting lots of different technologies. So as you answer this question, yes, we've already had adopted telehealth. We adopted it as a result of COVID-19 and are using one platform. We've adopted it due to COVID, but are using multiple. Many are doing kind of a shotgun approach at this point and seeing which sticks, what's the most effective for our consumers to adopt in a short window. Or if you're in the population that's not yet using it yet, we'd be curious to know that.
As the folks vote, Rick, I saw there was something in the Q&A from Amy about she was curious why pediatrics and internal medicine were so low. We can take a look. One is that was a % increase, so it could be that some of the IMs were already doing more of it. The pediatrics, and I don't have this, I don't have the data at my fingertips, but I suspect that folks are less likely to have their children because you can't really talk to the child. Interestingly, my wife works in veterinary health. And you can't do telehealth there because you can't talk to a dog, kind of thing, things along those lines. So I think with the pediatrics, it's going to be more difficult because especially younger children don't have the communication abilities. And then with the internal medicine, I'm not sure. Could be that some of that's just more done in the hospital as well.
And along those lines, I think it's also worth noting that weekly specialty, it's based on the most recent week where we feel we have that full picture of telehealth claims data. And I note that specifically because we saw orthopedic surgery at really high volumes early on. That has since become a little bit less in terms of a new jump compared to its previous year across the board. So that's not looking at all trends across all specialties throughout time. That's looking at those that have had the biggest jump within the past short weeks window. The orthopedic surgery one was interesting on a similar webinar to this a few months back. It came out as part of the discussion that there was a lot of pre and post-op appointments. There's even peer consulting occurring during those surgical events. So there's a lot that had moved that way, and it had jumped to, I think it was a 160,000% increase from where it had been that time the year before.
I'll give you an interesting one. This is somewhat anecdotal, but I heard this from a couple different places. We saw a little bit of a drop in ED emergency room docs in telehealth services, and what we found, especially because there was a geographic concentration to that, was that some of those practitioners would be providing that off hours. So they had set hours that they were working in a hospital, but they had contracts and they would do extra work to supplement their income and provide telehealth services, when they weren't in the hospital. Well, when COVID hit, they were in the hospital nonstop, so they stopped using it. So interesting. We were really curious about the one versus multiple platform things because we've heard that as well. And Rick, I'm interested that you see pretty much an equal distribution there. The majority of folks here have adopted telehealth during COVID. Not surprising, about 40% had already adopted it, with 8% still not using it. So we'll have a little bit more on this later when we get into some of the diseases and service line breakdowns of which types of patients are using telehealth services the most. Last section that we're going to get into today is how you can use data and analytics for operational recovery. At LexisNexis Risk Solutions, we're a data company. That's what we do at our core. I'm a data wonk. That's what I do at my core. So what you'll see here is we'll talk through, specifically we're going to focus around medical claims data and how some of that can be beneficial and provide insights both into COVID, post-pandemic, but then long-term operational recovery. So overall, just the type of data that you can use, the medical claims data on billions, 2.2 billion claims a year, hundreds of millions of patients, having a broad representative data set that updates daily. So a lot of the work that we're doing even these days shifted from looking at historical views to looking at what happened last week. So having access to that near real-time information, data that you acquire and merge from clearinghouses and government agencies and the state associations and things like that, and pulling all this together, because data and information, enough knowledge, that's what's going to help you to drive the right decisions, so that you're driving your decisions from a point of foundation of knowledge. Well, what can you get from the claims data itself? And if you flip to the next slide, you'll see the 837 form. So this is the professional HCFA 1500 837. The things you're able to get out of this: diagnosis, procedure codes, age, gender, location of the patient to a degree. There's HIPAAs in play here, as all of you know. Payers, practitioners, facilities, submitted charge amounts and things like that. This is great information if you use the claims view. It's often longitudinal, so you can track patients, things like that, to identify referral patterns and the like. Things like place of service, those are important, and modifiers. That's how telehealth is defined. For those of you who don't know, and if you're interested in this, because there are some questions, there's a lot of different ways that telehealth gets billed. There's a specific place of service code, there's modifier codes, there's specific CPT codes. I do expect that to centralize and become more standard as the AMA and the coding bodies start to formulate that. Right now, it is a little all over the place. I do expect some consolidation of how that gets done in coming years. The other type of claim information, this is really valuable type of knowledge, is the remittance side of things. And this ties into that, what's going to be coming out to the public. Now we'll see what comes out to the public and how all that plays out. But what's available to providers today is making sure you understand, what is the remittance, what are the allowables, what are the denial rates, the denial reasons, the adjustment codes, the patient out-of-pocket expenditure, tied to individual payers. So are different payers paying, what are the different negotiated rates they have with different providers? Where do we stack up in that relation? Are there areas that we have risk, or is the areas that we could potentially grow revenue and look at additional reimbursement? So having that line of sight from some remittance claims data provides some of the economic standpoint of this. That's sort of the foundation of what's in the data. Some of the things that come out of it, if you look at go to the next slide here. This is an interesting one. This is a trended view of the co-occurring diagnosis of COVID patients. So this is a national snapshot. It was April 1st that I think it's U071 was approved as an ICD-10 code. So we knew that it was getting diagnosed prior to that. A lot of pneumonia diagnosis and some other things that were being used. But if you look at like the third one there, you see that the big blue spike, that's in April, the co-occurrence of other pneumonia and how that dropped. That's probably has to do with some of the coding that was done. What we did on this slide here is we tracked the patients over time longitudinally within our data to say what, not just on the claim itself that was submitted by a hospital or something like that, but what are the comorbidities that these patients have presented with across healthcare over time. So not necessarily risk factors, but because can't necessarily say a cough is a risk factor, but these are some of the biggest co-occurrences on the individual patient longitudinal level that you see and how those have adjusted over time. Next one that you see here, this is from the CDC, so this isn't from our side, but I want to make a couple points on this here. This is recent. They released this, I believe it's in the footnotes if you're looking at that later. I believe it was August 6th. I can't read the small print from here, but this is what the hospitalization and death rates are by a number of age categories. They say they used the baseline of 18 to 29, and they looked at age buckets underneath of that, and then 10 or 15-year age brackets above that. And you can see, obviously, as we know, you get higher rates as you progress. There's obviously some information that they have, and CDC is doing a lot of work to help prevent the spread. But one of the things that I'm interested in following around this are some of the changes, both in the treatments. So the convalescent plasma UA that just got announced. Hopefully, as some of these treatments start to progress, we start to see a shift in those hospitalization rates and the death rates. And I think we're seeing a progression of that to a degree across the U.S. as there's been more treatments tested and more positive news that's coming out slowly as we move across. On the other side, we're starting to get into flu season. And what's going to be the impact of that as we shift towards the fall? Hopefully that our folks up in the northern climates and the areas that are going to see the flu season first are going to be able to benefit with some of the knowledge and the learnings of what they've seen and benefit and hopefully have less of an impact on the folks who have the flu season later. Then we can all kind of communally share in some insights of how that is going to, because obviously the flu is going to have some common symptoms and what's the impact of that flu diagnosis and flu shots and vaccines and then the like. So we'll see where that goes as we progress. This here shows a trend, and there was one that I love to point out on this, and I wish I could say I found it, but I'm working with a partner of ours who's a consultant in the hospital space, and we're looking at some knee replacement volumes. And we're doing a project for something in particular, but we wanted to trend out some data nationally as part of our project. And, you know, we knew that COVID fell off a cliff, so people stopped getting knee replacements. And we saw these spikes, and we identified every single one of these as holidays. So, you know, of course, people are not scheduling knee replacement surgeries at Christmas. You know, that's not surprising. But there was that one drop, and you see it on the far left, and couldn't figure it out. And it was a colleague of mine who said, the light bulb went off and said, oh, that's AAOS. And it was like hitting me with a hammer, like, of course, when all the orthopedic surgeons get together for their annual conference, they're not in the OR doing knee replacements. So, but this type of information, while the AAOS was an interesting tidbit that, you know, light bulb that went off, this is the type of information that can help. So looking at this data, especially in other markets, so the different hospital systems are at different stages of recovery. What are those procedures that are starting to come back up and where? Where are ASCs starting to open back up? Are there shifts in procedures going from outpatient to ambulatory to, you know, what are these changes that are happening? And again, this is national. It's not going to help with that exact question. But if you're 3 months behind pandemic levels of where another location was that has now opened back up and you're currently in a little bit of a shutdown, what are you going to see and what should you be preparing for? Because you can see the levels are getting back across the country. So hopefully there's some trending insights that you can leverage to help your business, especially if you can identify areas and markets of the country that have had a similar behavior to what you expect pandemic life to impact for your organization.
And Tim, I'd like to add that one area that this trend of information can also be insightful. I know looking at your own practitioner volumes, there's a way to quickly identify which areas you would expect a high number of potential backlog of elective procedures that have built up as a result of kind of that valley and cliff that we hit with COVID. So understanding which practitioners are likely to be affected, where there might be specialties that you need to bring in order to help support that as things do return and start going to normal. You know, that comparison is something that trended data over time can be very valuable to help you understand from a capacity planning standpoint long term.
So again, a lot of conversation around telehealth, and we know that's a big deal, but this is from, again, the claims data itself. So what are the diagnoses based on our service line definitions for telehealth claims? Almost 50% of them were mental health related. The top three, by a pretty substantial margin, I see 10 diagnosis codes that show up on telehealth claims: general anxiety, major depressive, and ADHD. Those are the top reasons. So as you start looking at your behavioral health parts of your organization, mental health parts of your organization, there's a lot of places out there that are doing that. And a lot of that doesn't have to be done by a local provider, but making sure that if you were providing those services before, those are patients that you want to keep within your network. You see general medicine, ENT, pulmonology. The question that we didn't do this analysis with any age breakout. So to Amy's question earlier, I'm going to do that. I'm curious now. I want to make a little mental note myself to look at pediatrics and see, is there a difference? Is there anything in pediatrics specifically? But here's sort of a breakout, and identifying there's certainly other systems and other places that are looking to get those patients that are in your market. So making sure that you're providing that same service so you're not losing your patients and that revenue that's absolutely critical to your organization, especially after what we just went through. And as you move ahead, a couple of the other things that you can do. So the remittance information, understanding what your allowables are compared to the other competitors in your market. This here is some IVIG. We pulled this because of some of the plasma discussions that are being involved in COVID related, but this is your IVIG medications for CIDP and PI and things like that. But you can see there is some variation here between United, between Medicare, between Blue Cross, et cetera, and where do you fall in each of those pillars? And if you're on the higher end, is there some risk? If you're on the lower end, is there some potential upside when the next round of fair negotiations comes into play? Similar, more detailed example on the next one is just getting into an actual MRI code and seeing that, United, what Aetna, what Blue Cross, Humana, Medicare are paying for specific, this is, I think, a spinal MRI. MRI is a little tricky as you get into it. You have to look at global and professional and technical and things like that. But having the line of sight into, what the actual reimbursements are, especially as this data is becoming more and more publicly available, having that line of sight is going to really enable some operational efficiencies to move in the right direction for your organization. And our last polling question of the day. Do you currently use claims data to track service line growth or trends? Yes, we track growth and trends internally. We use third-party data. We use a combination of internal and third-party data, and we do not. And I can see that Theodore's popping up on my screen with an answer of C. So we have some polling questions. I always like to have commentary so it's not awkward silence in the middle of the webinar. And let's see here. So half the people are tracking internally. A small percentage use third-party only. That makes sense. Would be surprised that you don't track your internal data. About a third using a combination and a small percentage that don't. So interesting findings. So as we get to the end here, there'll be a few minutes left for Q&A at the end. The three, we talk a lot on our side about the three legs of the stool, and some of this ties into our product suite, which is true, but it's also really important for whether it's your internal data or it's LexisNexis or anything like that. But looking at volumes, what are people doing? Whether that's what procedures are doctors doing at what facilities and their moonlighting, or whether that's trending and telehealth related services and what the impact of coronavirus is, but understanding the volumes of procedures and things happening at locations. Leg one. Leg two, where are those patients coming from? What's that referral patterns? How can we get our liaisons out to the community to get the patients into our system and make sure we keep them within our system? Whether that's at a service line level or systems of care, which looks at the network and the IDN level, but having that view of where those referral patterns are coming from. And then the third leg is the cost. So, at a simple level, understanding what's being done, out in the healthcare ecosystem, where those patients are coming from, so that knee replacement, where you're getting your referral from, and then the reimbursements, what's getting paid. So how are those telehealth claims getting reimbursed? How much are you getting paid for that MRI compared to others in your market? So, Rick, with that, I think the last one, the path forward, is over to you, and then we'll open it up for Q&A.
Thanks, Tim. And so, in terms of the path forward, there's three major areas that would encourage you all to focus. One is peer experiences. So If I'm, at a hospital that's currently shut down, being heavily impacted, what lessons can I learn from other hospitals that might be further along in terms of pandemic treatment, and similar size, similar response, similar volumes, and ultimately, where were there challenges over time? So being able to share that information, benefit from the lessons learned of your peers, it's a critical area that some of you will have the advantage to benefit from those lessons learned, as other areas have already overcome and kind of started to flatten the curve. As we look towards flu season, and specifically where flu co-occurring diagnosis, and ultimately how the two of those kind of impact one another in terms of the overarching health of the population, I think that's another area that you'll definitely want to benefit from looking at other parts of the company that might be experiencing it and collaborating with them on lessons learned and best practices to help mitigate it. Pandemic surges is another area. So obviously we've talked a little bit about resource gaps and critical care capacity gaps over the course of this webinar. So be thinking in terms of where those resources might need to be in a not only from a pre-pandemic lens of what volumes would typically have been there from some of those practitioners for elective surgeries and others, but suddenly aren't, but also where will they need to be in order to support that. We know obviously many of you will use different locum tenens providers or docs for hire to help plan ahead for surges as they start to occur. We can help identify where those are within the data. Comes from a different modifier on the claims. Those providers can also help create stock gaps for you as you might be in situations where your provider population is a little bit more heavily taxed in specific key areas. The last one is really the financial analysis piece and financial impact. So procedural spikes and those drops are obviously having a bottom line impact on your business. It's affecting and impacting your strategic planning as you're looking for how to staff not only appropriately now, but 6 months from now as the pandemic continues to progress. So gaining a better understanding of paid and allowables for the different procedures that you've got can help understand the financial impact and drop that can be forecasted. It also can help you kind of shift gears to a certain extent and understand which practitioners could move in adopting like telehealth services overall in order to maintain and baseline some of those revenues, keeping them consistent and also keeping that continuity of care for your patients, ultimately is needed to keep them in network long term. So I hope this is a couple lessons learned, a couple areas to think on and noodle on as you're looking at the upcoming months and really the unknown that still lays ahead of us with the ebbs and flows of the pandemic and its different resurges within our geographies. At this point, we'd like to shift over to more open Q&A and take an opportunity to hear from some of you in the audience.
Well, thank you, Rick and Tim, for that engaging presentation. To our audience, if you have questions, just go down to the bottom of the Zoom window and click on Q&A, and you can type your questions in the Q&A box. Our first question is, how can claims data help in recovering lost service business due to COVID-19?
That's a good question. So the lost service business, one of the things that we're going to find out over time is how much of that was lost versus how much of that was lost temporarily. So the knee replacements are probably all still going to happen, but the annual mammogram probably isn't. And there's probably a lot of those that went away and that are going to skip a year or something along those lines. But I do think that looking at trends, especially geographically over in other periods, so looking at what happened in Manhattan and New Jersey and in Seattle, and seeing whether, again, you have to look at it by procedure because it's going to be different for your routine colonoscopy versus a spinal stenosis procedure. But I think looking at the other markets to identify what volume came back, and identify which of those things there are. And it might be that you can identify some of those in other markets that don't seem to be coming back. So you really should do some push out in the community to remind people, hey, it really is important to get your colonoscopy done. Don't just wait till next year. We are safe. We should be doing those things. So I think that's a great question. Rick, any other thoughts on that one?
No, Tim, I think you're spot on. I think right now we're expecting that most of those delayed and kind of backlogged procedures will resurge at some point. So staffing and planning for that. Telehealth is an area, though. I see we've got another question that has come in on the poll. But telehealth is an area that I think overall we have an opportunity to start to recoup some of those lost procedural volumes just as a result of providers adopting an alternate means to have communication with those patients. So for our next question, I'll go ahead and read it. So we've got an opportunity to talk a little bit about this. Someone asked, Once the lift on pay parity and break on credentialing and tech requirements, what will this do to telehealth? Do you believe the numbers of providers will shrink? Do you think payers will be more lenient? Overall, I think, and this is coming from Victoria, I think these volumes will remain fairly high. We have seen some dips as opening has reemerged, and practitioners and patients are starting to become a little bit more comfortable going back face to face. But I can also tell you that I would expect that shift in behavior across the board to be adopted by our consumer population long term. How many of you might have stopped for a cup of coffee on the way to work every day? How many of you are used to getting into a car? And we're all telecommuting right now and talking live on a webinar instead of doing some of these things face to face. Many of those behaviors, I think, will be long-term shifts that we'll see adopted within our society as some of those things we've recognized we can go without. And as a result, I suspect a lot of practitioners, whether they use telehealth as a primary method for outreach and communication with their population or not, will continue to do it because it opens up greater accessibility to their patient population than what they've had historically. Tim, do you have any thoughts on that one as well?
No, I mean, I think you hit the nail on the head. I think we're going to find the sweet spot of what are the right things that work virtually and which ones don't. I think counseling and mental health disorders and those type of things in person is still going to have some value, but a lot of that can be done virtually and might be preferred. There are certain patients that don't want to leave that might have their home in those disorders. You might see an increase in those. I do think the payers will become more lenient. I think consumers are going to push for it, so there's not going to be a choice. And I think that the consumerism model and those things is going to really push for. It's not going to stay anywhere near the peak of what it was. There's no question about that, but I think those are here to stay. The next question from Abdul is the event that patients not happy with telehealth or with teleconsult. Look, I don't know the answer to that. It's a really good question. It's funny because we live in the data world. Not that I want to ask my sister. She's a pediatrician, and what do you do that that's sort of a bedside manner type thing. And certainly there's going to be some patients that thing works well for. There's also going to be some practitioners that are good at it and some that aren't. So, when they're not happy, I got to punt on that question. I think that just truly is out of my wheelhouse. And I would punt on the experts to, so we're going to note from Angela, one more question. We'll pick one here that we do have some. How do you qualify net revenue impact from claims data as well as denial management? So yeah, that's coming from the remitted claims, the 835 claims. The net revenue impact, net is tough to see. Gross, we're going to see. So when you're talking about net, if you're looking at operating expenses, what you can see from claims data is what the allowed were between the payer and the provider for a given procedure. Denial management, that there's a really good answer for because there's adjustment codes on those claims. And then there's adjustment codes that get into denial reasons. You can look at the rates. You can see that the amount paid was zero. The amount that went to the patient, you can see the reason from it. So yeah, denial management, denial rates, reasons, patient out of pocket, that's all available from remitted claims data. And I know, Angela, I want to respect the moderators here. I think Rick and I would love to go on and spend more time with everybody here, but really love the questions, and thank you all for your time today. So much thanks for the time, and Linda, Angela, we'll turn it back over to you.
Well, we've reached the conclusion of today's webinar presentation. Thank you very much to our speakers for presenting and for LexisNexis Risk Solutions Healthcare for sponsoring this very timely presentation. And we hope that everybody has found it informative. So if you have any further questions about this webinar, you can email them to resourcecenter@hfma.org. And our Resource Center staff will assist with questions that we're not able to answer during this webinar. And then you can also sign up for upcoming webinars via our website at hfma.org. Thank you, everyone, so much for your participation, and we hope you have a great day.
Thank you, everybody. Have a great day.
Thank you.